Okay. All right. So once again, welcome everyone, and I will turn things over to my colleague Carrie Sawyer, the Health Access Coordinator at Nationality Service Center, to introduce our speaker.
Hi, everyone. Thank you so much for joining us this afternoon. Very excited you can all be here and join us in learning from Dr. Garcia, one of our wonderful partner providers at Penn Medicine. She is the assistant professor of clinical family medicine and community health um, at the University of Pennsylvania. And we just have the honor and joy of working with her and our clients. Just housekeeping, we will save some time at the end for questions. So if you have any questions along the way about content, if you want to drop those in the chat, we can circle back to them at the end. But once again, thank you all for being here. And with that, I will turn it over to Dr. Garcia.
All right. Thank you guys for coming in today to chat about a very exciting topic, actually many topics. So you tell me, I'm happy to tailor this. I want to create this lecture series where we talk about common medical conditions. And so if there are any that pop in your head that you'd like to learn a little bit more about, send it to Carrie. I'm happy to do that in part two. Let's see. There we are. Just a little bit about me. I started my career as a nurse. So very long time ago, I was a hematology oncology nurse. That was my initial training. And then I did medical school and residency at Jefferson, actually, with Mark Altshuler et al. In refugee health there. Currently, I'm at University of Pennsylvania, and I'm a family medicine physician. So that means I see babies, prenatal of all ages, but I specifically specialize in HIV, hepatitis, and primary care. And I'm also board certified in family medicine and addiction medicine. So I can be a resource to you if you have any questions in any aspect of that care in conjunction with your own physicians that you work with at your own locations. No financial disclosures, but again, I think just a disclosure that this is a very all-encompassing topic. So it is very whittled down to address some of the initial things for you to consider. So first of all, what do I do? I think for me, I'm a family medicine doctor, so that means primary care. And I want to introduce you to something called, if you haven't heard of it, it's the patient-centered medical home model of primary care. It's doing things a little bit differently so that the patient has basically one mechanic, so to speak. And how does that work in primary care? And how can we partner with our physicians who do that kind of primary care for their patients? We're going to become familiar with some common medical conditions. And ultimately, I hope that in partnering together, we can help patients navigate healthcare systems and just, to better help their own health and for self-sufficiency in that regard. So here's a broad overview. When you see the patients come in, that initial 30 days, that's the medical evaluation clinic. And that can happen anywhere. That's, where there's a physician, a nurse practitioner, or a DO trained primary care doctor. Anyone can do the medical evaluation within the 30 days of arrival. And you know what that looks like, the lab tests, perhaps the mammogram, perhaps the PAP, and many of the vaccinations. But then they get graduated to that primary care. But I want to introduce you, if you don't know it already, the patient-centered medical home model of primary care. And in this sense, this is what we aim to give to our patients, is not only do we do chronic disease management, chronic conditions care, they'll get their annual checks for adults, for children, appropriate for age appropriate. And then any sick visits. For us in family medicine, we do prenatal care. We also deliver our own babies. We do hospital care. We do all of it under this patient-centered medical home model. The common medical conditions we'll touch base on today, tuberculosis and latent TB, just reminders and things to consider when you're working with clients who may have these conditions. H. pylori, because it's so common. We're going to just review quickly the pre-exposure prophylaxis that they do receive prior to arriving in the US. And again, my specialties of hepatitis or hepatitis C and B, again, brief overview, and how to look at HIV in a primary care lens. There are many other conditions, mental health, lead, vitamin B12 deficiencies. It's very broad. So think of topics you'd like to know, birth control, whatever you want, prenatal care, anything that you are interested in. I'm happy to consider those for part 2 and onwards. This may be a good one for next time. The medical conditions common that are non-transmissible. So this is more for primary care. Diabetes, hypertension, high cholesterol, thyroid concerns, and then being familiar with what we call preventive cancer screenings, and the frequencies of those testing over time for your clients. In addition, because I'm family medicine, the prenatal care and the pediatric portion of also preventive care. You know this already, but again, briefly, refugee camps or clients in refugee camps to the left, during their vetting process, they'll get that medical exam, and then they'll arrive in CDC quarantine stations for another reevaluation for tuberculosis and other infections, and then they get resettled into their communities, and within 30 days, they'll come see us. And so again, a catastrophic event and displacement, they all have somewhat of unique health challenges, but somewhat similar in a sense, because they're at the mercy of the host country that accepted them. And in many cases, those host countries are some of the poorest in the world. And so they're also, vulnerable to climate change, a lot of lack of healthcare, insufficient vaccinations. And of course, just with that catastrophic event, we're always thinking about the role of trauma in all of our patients. The health challenges that I've identified, many are common to you guys: malnutrition, infectious parasitic, mental health, of course. The one thing I want to say about chronic conditions, number 5, sometimes when they are in the state of having fled somewhere and they're in that state of transitory location, like a refugee camp, chronic conditions are not always addressed. When we talk about patient-centered medical home with our patients, it's the idea that they also have to enculturate in how to take care of themselves in a preventive manner rather than in a way of treating things when the symptoms or sequelae have caused significant disability already, where they're already missing work. We're trying to catch up to treat them, where we have to perhaps teach them what it is like to prevent said chronic conditions. So that's also very important to consider in our partnership as they acclimate, okay, here in the US. So very brief, guys, overview of what they get before they come here. And I'm going to make these slides available to you so you can use them as a reference. I've portioned them out in 4 settings. So you're going to get the medical history and the physical exam. You're going to get the tuberculosis screening, the STI or sexually transmitted infection testing, and then a portion or perhaps some modicum of mental health screening. And, really those are things to address any of the conditions that we talked about that they may have been exposed to. Definitely tuberculosis because it is very highly transmissible, and the STI testing because obviously it's also transmissible. And then in mental health, perhaps some of the things that we'll start with is usually substance use disorder. But for the most part, it's not well addressed unless they were on medications or they have had significant trauma where they've required a psychiatrist evaluation. And then, of course, they're going to get vaccines, but the vaccines vary by refugee camp or medical evaluation center. Some vaccines, for example, I'll give COVID as an example. They'll have the Chinese COVID vaccines, or they'll have the AstraZeneca or the Johnson & Johnson, so it can vary. Again, briefly, they'll go through the screenings. They'll get the pre-departure screening, especially for tuberculosis. And then prior to leaving, they'll get the presumptive pre-exposure prophylaxis for common diseases like soil-transmitted helminths and all the rest, which we'll go through. So welcome to Pennsylvania. Again, our clinic, we started August of 2023 at Pennsylvania Hospital, which is on the right-hand corner there. One of my partners now is Dr. Sweta Iruku. She's one of our laborists as well. So she delivers our babies that we take care of in our prenatal clinic at Hospital University of Pennsylvania. And we also have a fellow with us, Dr. Saad Siddiqui, who is spending half his time in Guatemala. Oops. Let's see, my Sorry, my slides are not advancing. This is, so the top clinic there is where we have the medical evaluation. The bottom clinic there is where we would have our continued primary care. So of the patients, especially who are living in West Philly, they will transfer over. And again, there's a difference between the medical evaluation clinic and the primary care clinic. So I'm going to just give us a brief review of these two patients that just arrived like last year. And you'll see that they'll get the TB evaluation, the parasitic prophylaxis, but they'll also get the age-appropriate screenings, and then hopefully at the end, primary care. And we've continued to see them over time after they've come to us. This is what it looks like at the 30 days. And I'll just review this briefly. This will be given to you, and you are familiar with this in a sense of what they get when they first arrive and what the doctors like me obtain and try to get with the labs and everything else. These are all the testing that we do, so you can familiarize yourselves with that. And then with primary care, this is where we work our best, right? Where we continue with discussing their labs, giving them any other vaccines they need, doing some preventive medicine, and then at graduation to primary care, chronic conditions management. So for these two, I'm going to give these to you. This is what I give the doctors and the residents, just so you have an idea of what we look at. But for this gentleman on the top right-hand corner is quantiferon positive, and the H. pylori is also positive. He has almost diabetes and high cholesterol risk, or ASCVD risk. For this gentleman, also the same with what he went through in our clinic, but you could see that he had hepatitis B history, but he cleared it and he has immunity. Quantiferon was negative, but he's positive for those parasitic infections. And so I just want us to think about those two patients, and you're going to get these slides, like I said before, so you could sort of review them and familiarize yourself with what the physicians do in the clinics and these medical evaluations. So the first condition we're going to talk about is tuberculosis disease versus tuberculosis infection. Tuberculosis is what we usually call tuberculosis, like TB, and TB infection is what we normally call latent TB or latent tuberculosis. The CDC has changed the designation, and these are what we commonly call them now. I think the most important thing to know about TB is that it's a bacterial disease that is just highly transmissible. It is spread through the air. And so also very important, it's preventable and it's curable. And so it is the one that we screen prior to departure, upon arrival at the quarantine CDC stations, and again when they see us in the medical evaluation clinic. What's more, we don't stop just there, because they can also have symptoms. So if anyone is coughing and has a potential risk because of exposure, it's something that we keep in mind in primary care over time. What we call latent TB, though it's actually people who are infected with tuberculosis but are actually free of disease. So they are not transmitting it. It's not active. And these are, we will show you later why we do the quantiferon, and they're the ones that come up as positive without any pulmonary symptoms or any other extrapulmonary symptoms. In certain countries, if you've heard of the BCG vaccines, the Bacille, Calmette, Guerin vaccines, or BCG, sometimes that will turn a tuberculin skin test positive, but should have a negative quantiferon blood test if the patient is truly negative of TB infection. So tuberculosis disease, it's the symptoms that I'd like you to consider that are most common, really easy: fever, cough, difficulty breathing or dyspnea, weight loss, night sweats, usually 2 weeks or 3-week duration. In children, the most common symptoms are fever, cough, and failure to thrive or a decrease in body weight. Again, it's a duration that's long, so maybe 2 weeks, 3 weeks, but always good to have in your differential. And it's something that we will ask patients if they have any of those symptoms during their medical evaluation with us. How do you diagnose somebody who has the actual tuberculosis disease? So they're coughing at you, they tell you they've been losing weight, they're sweating at night. The doctors will usually try to get 3 sputum cultures and NAA testing. So just for you to know, we will need 3 days of sputum culture. and preferably in the morning. So what we hope is that they haven't coughed up anything, or they'll try to hold their cough. They'll go to the lab, and then the first thing that they hack out is what we would really love to collect. That's what that means. We can also get it through other means like bronchoalveolar lavage or tissue samples, but for our purposes in the outpatient clinic, if we suspect somebody has TB, I'd really love to get that first morning spit sample so we can determine if they have an infection. And then a chest x-ray. This is a chest x-ray of a patient of mine who had a reactivation of disease, and they tend to like the top part there. So you can see my arrow at the top right-hand apical area. You'll see a mass there, or an obliteration there. That's usually where TB likes to hang out, and that's what we'll see in that chest x-ray. So let's think in our minds, this is an acute infection, okay? Somebody has symptoms. We got to figure out if they really have TB. And the first thing we do is I'd really love to have that spit, and I'm going to send them for a chest x-ray, okay? And, if you know that they're coughing, it may be a good idea to give them a mask. An N95 is what we need for tuberculosis, but, that's not always easily available, but it is something that may be, warranted if you note that. Again, the CDC will ask them questions and test them once they arrive in the country, but there's still 30 days between then and arrival to us to see them, where they could be exposed or just, be indolent before they show any symptoms. So any of those things are possible. What are the treatments? We'll keep it simple for you guys. We give them a choice of two types of treatment. Either one that's short, it's on your left, or one that's a little bit prolonged, which is the traditional regimen that you are all aware of. There are recent studies that the CDC has published where the short one on the left is just as good as the 6 or 9 month traditional regimen. It's just that there are certain caveats of who can receive it. And it's usually people older than 12 years old, people who are greater than 40 kilograms. They've not had any kind of aborted TB treatment in the last 6 months, or any exposure to any of that regimen that was given to them. And they don't have a cardiac condition where we would be worried for dysrhythmia or a problem with their heart. And again, on the right is the actual traditional treatment. Again, these on the top that's bolded are the medications we usually give. And then any treatment for TB has 2 phases, okay? It's the intensive phase and the continuation phase. And you can see I've outlined it for you. The intensive phase, it's 8 weeks or 2 months, and they all have to get all 4 of the medicines. Versus the continuation phase is a little bit of a longer duration, but only 2 medications at that time. The doctor can decide if they need to add more medications, but for now, those are the things that you need to understand. Is if you got a patient who is going to undergo some sort of treatment for TB, it would be important to know the duration of the medications, and that to make sure that are they really receiving all 4 treatments when they're supposed to be, or all 2 treatments when they're supposed to be, or not. And then remember, this is the part where you may accompany them for the spit, the morning spit or sputum cultures. And so we retest them at the end of the intensive portion of the traditional regimen, and monthly for the 4-month short regimen. And again, you're going to get a copy of these. So this is the consideration. We really can only transmit tuberculosis through aerosolized air. So anyone that coughs or speaking and you're within distance of that sputum, that's how you can get tuberculosis. So it's very important for us to really get anyone, or be suspicious of anyone who may be transmitted. During their treatment, they should undergo something we call directly observed therapy, meaning we really like for them to take all the pills every single day with no missed doses. And overseas, what we would do is that they would actually come to the clinic every day and we would give them the pills to swallow. We don't tend to do that here, but the Department of Public Health may do that if indicated. Wearing the N95 mask while they're symptomatic is really important. And then what do we do about household members? People who may have been exposed. In a sense, we can't really test them. We have to call the CDC or let the Department of Public Health know that there was a household contact for TB. And usually we would monitor them for any symptoms that they may have. We will ask them to isolate from the patient who's getting the treatment if they're still symptomatic, wearing the mask, very similar to COVID in a sense. And then it may take about 2 weeks before we can really do a tuberculin skin test, and the quantiferon may be at minimum 4 weeks before we could really test them. But in addition, these tests depends on the patient, the family member, and the physician will make that discretion of what kind of test they should do for the patient who may have been exposed. So latent tuberculosis, I'd like you to get used to calling it TBI or just latent TB infection. In the US, TB is not really a big incidence. The numbers are going down. However, the numbers that are causing tubercular infections in the US are due to reactivated latent tuberculosis. And that's the reason why we're really diligent about testing. In addition, refugees and immigrants within the first year of arrival tend to reactivate within the first 1 to 2 years. And so that's the reason why we treat them for latent tuberculosis infection. And again, over time, if they're having a cough, the doctor usually maintains a high degree of suspicion for any reactivation of that infection. Overseas, kids will get the tuberculin skin test. Kids over 2 years old will get the blood test or the skin test. The adults, for me, I've seen more of the chest X-ray and hardly any of the blood tests of our recent arrivals. And they'll treat them as best they can, and they'll note it in that medical evaluation form. And then prior to departure, within that 6-month window, they'll repeat that testing again if it's been more than 6 months, and they'll monitor for the signs and symptoms. And then upon arrival, we already talked about what we would do is screening them in the CDC quarantine stations, and again at 30 days when they come see us for their medical evaluation. So latent TB, this is the one that's positive for the quantiferon blood test. This is most often used rather than the skin test, because the skin test requires the client coming back at 48 and 72 hours, which is very difficult for them, so that it's much easier for us to just do the blood test. Is there a difference? The CDC recommendations, no, they're about similar. They're similar essentially. And then we will ask the questions if they have any, what did we say? Fever, cough, weight loss, night sweats, those kinds of things. The extrapulmonary symptoms are very much like lymphadenitis or big lymph nodes, headaches, where we would be worried about meningitis and things, but they're pretty sick if that happens. So, and then we would, if it's positive, do the chest X-ray, which you guys will help with. And as you saw, that's what we're looking for, is that cavitary lesion that we would find in the X-ray. And then if it's ruled out, okay, this person does not have tubercular disease. They only have infection. So nothing in the lungs to transmit. Okay, I've ruled that out. Then I can just give them the one treatment, the one medication, rifampin, instead of the 4 medications for tuberculosis. And this one is rifampin is 4-month therapy. And I'll go over what the others are. It has many drug interactions. So I usually partner with my pharmacist with this to guide the patients. And we usually confirm adherence. So she'll call them often and be like, are you taking your medications? Are there days that you've missed? Did you pick up the refill? Because that might be one where they're thinking, wait a minute, did we complete the 4 months? So you could be mindful of that. If somebody's getting a latent TB or TB infection treatment, I'm thinking 4 months. Did they pick up all those pills every single month that they were really written for? It would be one way to help them understand adherence. And then we'll take care of the side effects. But the one notable one is that it turns body fluids orange. So their sweat, their tears, their urine may turn a nice, lovely orange hue. And that's not adverse or bad, but it can be distressing to the patient and cause them to stop. we will try to give them a handout with all of those side effects so that they're very aware. There are many recommendations. There are recommendations for treatment of LTBI, but I go with rifampin because of the short duration of 4 months. It has increased adherence and has decreased also the side effect profile of isoniazid. So it's the one that I do give. And it's only 1 tablet versus the other one is 2. The others are 6, 6 months of 1 tablet, so there's, I think it's the one that has the least problem for our patients. And again, this is the Minnesota Department of Health that has these handouts in different languages, and they've been really helpful, and my patients have really liked them. So we're going to switch gears. You guys okay? We're still okay. All right. Per your request, H. pylori. All right. So it's a stomach infection. It's a bacteria. It can cause things as innocuous as gastritis, reflux, gastritis or dyspepsia, fancy words for saying acid reflux. But it can actually cause pain to the point where if you've had these for many years, you can get a peptic ulcer. It can also turn into cancer. So these are actually significant infections that we really should be like not dismissing them about and not just giving them antacids for. So I do, because in immigrants and in refugees, this is a common condition. So let's see, what are the testing? How can we test for H. pylori? Well, there's a few ways to test. There's one biopsy that needs to be done by a specialist when they do the EGDs, but the rest of them we could do outpatient. Some places like FQHCs or other medical clinics have the breath test bags in their labs. We use the stool antigen. We no longer have the blood test. We used to. So those are the tests that we'll review. And then the treatments are, there's the triple therapy that I still try out because it's very simple versus the quad therapy. And then there's other complicated regimens, but the bottom line is the treatment should be completed. It's 2 weeks, and that we do a test of cure. There are recommendations for in 1 month, but I tend to wait the full 2 months before I retest folks. So the breath test. We have to tell our patients that 14 days prior to the test, we have to make sure they have no antibiotics recently taken, no PPIs, that's the acronym for proton pump inhibitors or acid reducers, no bismuth containing medications because that is an acid reducer, no barium. So that's very important. And then 1 day or 24 hours before the test, you can stop the other antacid like Pepcid or Zantac, okay? And then 1 hour before the test, no food or drink. So what you're gonna do when they do the test is you're gonna swallow this really nasty like carbonated drink, and you're gonna try not to burp. You're gonna try not to open your mouth because you really want that bacteria to turn all of that urea into carbon dioxide, okay? And then they're going to wait 15 minutes and you're going to exhale all that breath that you kept in there into a special bag. And that's what's going to tell us if it's a positive test or a negative test. And it's very short, but we have to really just prepare the patients well. Okay, and then let's say they completed their antibiotic therapy. We can do this test as a test of cure in 2 months. The stool antigen, which we've done also. You can do this in the lab or you can do this at home. I usually send my patients with the kit for home because it's very difficult to do, on the fly in a lab. But they will collect your stool. You put it into the bottle with the little scooper, and you will be provided with a label with the name on it, and then that's it. The blood, so this one tests the antigen, so the presence of the actual bacteria. This tests the bacteria because if it's breathing in your stomach, it's gonna convert that urea. But the blood test, that's why there's little utility to this one, is it's the antibodies to the infection. Meaning, what if you had an infection 5 years ago? If I did a blood test today, that's gonna turn positive, but you might not have an infection today. It was probably from 5 years ago. So that's the difficulty with this test. For refugees, it's very easy for us to do because they probably had never gotten treated for H. pylori overseas. And so I do still use it because there's little barriers for patients, like there's more barriers for patients with the fancier test versus just a straight up blood test. But I will not use this for a test of cure. Treatment, again, on the left is the triple, and on the right is the quad, and both are 2-week duration, and both have many medications on together, okay? Because you're trying to really kill the bacteria from multiple angles. To prevent resistance. The most important thing is to complete it without missing any doses and to do the test of cure within 1 to 2 months. And again, I usually do it at 2 months. So very easy, 2 types of treatment, 2-week duration, just like TB, don't miss any doses, take the whole thing, and then in 2 months, retest. Okay. I put in pre-departure prophylaxis just for us to understand a little bit of some of the medications they're given and why. These are given because certain infections can cause significant sequelae in the US if it reactivates. So they're given either albendazole and plus ivermectin and plus praziquantel and plus coartem. And these are for soil-transmitted helminths or worms, strongyloides, schistosoma, and malaria. Just so you're aware, through the CDC's EDN or electronic disease notification, we can find out about the tuberculosis status of screening, and we can find out if they were given this. But sometimes if it's not there, the patients usually have some paperwork that they can bring in that shows that they were given those medications. This is again because they may be asymptomatic when they come in, but the disease burden is really high if they do reactivate while they are in the US. So they are given usually those pre-exposure prophylaxis prior to departure, usually like 1 to 3 days beforehand. And here's a brief one from the CDC that you'll just see here. This is coartem for malaria, like we talked about, schisto with praziquantel, albendazole for the soil-transmitted helminths, and ivermectin. So I'm saying this because I had a family of a Russian family today who didn't receive these, and it's very expensive for me to try to get albendazole. It's about $440 in the U.S. versus it's like $4 in overseas. So I don't know if I'll be able to get that. But if I were to just check their strongyloides in their serum, I don't have to technically give them their ivermectin, but the albendazole I'd prefer to give them just to cover them for any other parasites. And you can see here their recommendations, which you can review this later. Malaria too can reactivate, okay? And so they, for those who are at risk, because more than for those who are at risk, they do receive coartem prior to arrival. And these are the medications that we give as directly observed therapies. All right, you guys doing okay? All right, pushing through. Hepatitis C. Okay. The thing to note here is that it is curable. That's it. Okay, so if you see it, if your physician tells you that the patient has it, that physician can treat or refer to somebody like me who's trained to treat rather than a hepatologist or a specialist, because we don't have enough hepatologists to treat hepatitis C. There's an epidemic right now of it from injection drug use transmission. And so, we are fully equipped to be able to treat it if needed. A couple of things, there's no vaccine for it, okay? And there's a simple treatment algorithm. I'll go over what a fibroscan is because you will be taking your patients to get this study. And after the cure, you gotta wait 12 weeks. And then that's when we do the blood test. And that's it. So unless they started having new risk factors, new sex partner, new tattoos from somewhere, they started injecting drugs, they went to a country or, where Hep C is highly endemic, that's the only time we would rescreen them. And then we think about, because I'm family medicine, I think about the family. Did we screen the family members? Did we vaccinate for the other alphabet soup hepatitis or hepatitis A and B? This is a fibroscan. It looks at the elasticity of the liver. It is different from an ultrasound. An ultrasound will look at what the liver looks like, but this one looks at how soft the liver is. And it propagates a sound wave through the liver parenchyma or the liver tissue. And you will sometimes be called upon to bring your clients to a facility that has a fibroscan. And all you need to tell them is, do not eat anything 3 hours prior to this appointment. That's it. The medications for hepatitis C treatment and cure, 2 types. And I will tell the patient, I'll give them an option. Do you want something that's 8 weeks, very short? Or do you want something that's 1 pill a day, but it's 12 weeks? And so you can see right there, Glecpib or Mavorite, it's 3 tablets that you take at the same time every day, but 2 months only. So sometimes for patients who may have a lot of pills, that's very difficult for them to do. And then the other one is only 1 tablet, and it's for 12 weeks. And don't worry about the bottom one, but it's for 12 weeks. And the most important thing for Hep C treatment is that they don't miss doses, that they finish the whole thing. Let's say they're going to go to an ER. You're going to accompany them to the ER because they're going to go to, I don't know, for whatever reason. Tell them to bring these meds so that while they're in the ER and they're waiting 12 hours, 48 hours in the ER, they don't miss their doses. They're going on vacation. That's not usually common, but if they're going to visit a family member, they should really bring these meds so that they don't miss it. Okay? Because it is harder to finish the treatment if we needed to restart it. So again, during that 8-week course or that 12-week course, usually they won't need any laboratory monitoring. I very simplified this. I work with my pharmacists on looking at other medications they're on and other interactions. But for your purposes today, this is just the bare bones of what you need to know. So no labs during the treatment, but after they finish the last tablet, 12 weeks from that date, I'd really love to check their liver again. That's the CMP or the metabolic panel, and the viral load of hepatitis C. And again, no need to test them again for any hepatitis C because they are cured, okay? Unless they have new risk factors where you think that they have a new hepatitis infection. Okay, see, Hep B. Now, Hep B is a little different. Hep B is what we call an oncogenic virus, meaning it's a virus that actually its very presence can cause cancer. And it's indolent. It's in all of like the rest of the world, it is a very common infection. The chronicity of the infection, because it's oncogenic, puts the patient at risk for liver failure or cirrhosis, and especially liver cancer or hepatocellular carcinoma, HCC. It can spread through bodily fluids, but the thing with hepatitis C is we have a vaccine, so we can prevent it. So that's the most important thing. So when refugees come in, of course, we're looking for their titers. And for me, I try to complete the 3 series of vaccines, even if it says that they have, immunity, because I want to give them a full, robust response to against hepatitis B. Again, there is treatment, but it's not like hepatitis C where there's a cure. We have what we call a functional cure only, but they will still, anyone with chronic hepatitis B will need close monitoring with labs. You remember the fibroscan? I try to do that at least once. And then the HCC screening, cancer screening is it's called. We do an ultrasound and a blood test AFP every 6 months. So it is something that needs monitoring. And, you can notify any of us to help guide that. But if just for your own purposes, knowing that somebody has a history of chronic Hep B requires a little bit more monitoring than the other ones. And again, for family members, very important to screen and then vaccinate them as well against hepatitis B and A, especially their spouses. All right, how we doing? Okay, this is the last one today because I think I gave you a lot. I want you to consider, because it's my specialty, HIV. HIV in this day and age is basically a condition that is best cared for in primary care. We have such great medications or antiretroviral therapy that many times they don't really need an infectious disease doctor to take care of their HIV. In their initial medical evaluation, the doctors can assess if they still need an ID doc to help. Like what if they have tuberculosis also, and maybe you're not comfortable with the medications they can take? You can send them to ID. But I found that for our refugee patients, it's much nicer in the patient-centered medical home that the HIV can be taken care of by their primary care doctor, because it's kind of like diabetes. High blood pressure, right? It's sort of the same thing. It's a chronic condition where they have chronic medications they're taking for a really long time, and we're watching them with labs and vaccinations. So it's very similar, and that's why I think primary care does a really good job with HIV. So it's a chronic condition. There are going to be 3-month visits in the initial couple of years until we know that they're stable on their medications, and then also every 3 months of labs and testing. In HIV, because of their immunologic state, there are specialized cancer screenings and earlier cancer screenings. For example, the cervical pap is only every 3 years. It's never every 5 for people. If you are a female and you had an abnormal cervical pap, we will do an anal pap because of the risks of cancer. There are other screenings like hepatitis C, STDs, quantiferon, because they're at risk for any of those. In addition, because of the medications they're taking, they're at risk for osteoporosis. So we'll do a DEXA. So you can see how all we need to know is just how to care for them chronically. And then vaccines. Most important, no missed doses of antiretroviral medications. Very, very, very important. So the idea of going to your pharmacy for your refills, really reinforced, very, very needs to be really reinforced. We have 2 forms of medications for HIV. One is pills. They can be on 1 tablet or they can be on several. I try to get them on the 1 tablet if I can. And then I try to get them on the second form, which is the injectable form, if I can. So let's take our, we're talking about our refugee patients. So, having HIV does not preclude you from coming to the US. You can arrive here, you're stable, it's as if you have diabetes, you have this medication. Because if you are viral load undetectable, you are not transmissible. Okay, so so if your viral load is undetectable, you can you are safe to have sex with your monogamous partner without a condom. You are not going to transmit it. So the most important thing then is that we make sure that they get their medications. Okay. More, of course, to be continued for any other conditions you've identified for me to do. Do you have any questions?
Thank you, Dr. Garcia. That was so much amazing information. So thank you for opening it up for questions. Does anyone have any questions to ask?
No, the one I was about to ask, she had already answered, so I appreciate that.
Perfect. I do have one myself, actually, regarding hepatitis B and the 3 different tests that people usually take. I've just always been confused about that because they, like what do the three different tests mean? And yeah.
Yeah, let's see. I wish I had a blackboard. Um, I'm gonna do a Word document and maybe that'll help. Uh,
Okay, let's do it.
and then let's see here, share. All right, are you able to see my Word document?
Yes.
Okay, so you mentioned, can everybody see it or is it too small?
Um, it might help to make it a little bigger, just to make sure.
Okay,
There we
right?
go. Nice and big.
So this is Hep B. What we look for is the surface antigen. Okay. If it's positive, then they have an infection. If it's negative, they don't have an infection.
Hmm.
So whenever we do hepatitis B, we do not stop there. We do not stop there because we do Hep B for antibody. Okay. So if they have an infection, it could be positive. So they have an acute infection that's greater than 2 weeks at least. So they were able to make an antibody, right? It could also be surface antigen negative. See the top, surface antigen negative right here, surface antigen negative. But it could be positive Hep B core antibody. So that means that that person has a history of an
Hmm.
infection. Okay. So and then Hep B, okay, surface. And I'm using these designations because I want you to feel comfortable with how doctors kind of annotate things because they'll probably start writing it this way, not thinking to change it. So an antibody. So the surface antigen at the top tells you an acute infection. The surface antibody means, okay, let's say they're usually negative if you have an acute infection. Okay? And sometimes, even if you've cleared the initial infection and you only have a history now, it kind of varies whether you made antibodies or you didn't. Okay. And then sometimes there may be instances where this is everything is negative and this is positive. Sorry, I should just do it this way. Positive, right? But this is negative and this is negative. And this is what we look for in somebody who is vaccinated. Okay.
Okay, so that's what that means.
Yeah. So let's start. I want you to just get familiar with the three. So surface antigen and core antibody, surface antibody. So if it's surface antigen positive, right? And they have core antibody positive also, that probably means they have an infection going on and they haven't developed any antibodies to protect themselves. And let's say it's negative. That's why you don't stop with just one for screening. You got to get the core antibody. Because if it's positive, that means they have a history of hepatitis B. Okay? If they had a positive surface antibody, that means they are immune, which is great. They had an infection, their immune system is so good, they cleared it, they're immune. But if it was the negative one, that means that they are not able to develop antibodies. This is somebody that we will not give a vaccine to. The vaccine somehow doesn't work in these patients. Somebody who has this history right here of negative, but it's chronic hepatitis B, but it's negative antibody. If you're HIV positive, we will still give you the vaccine. But for a person who's not HIV positive, will not need or respond to a vaccine. And then this last one, where this is negative, but this is positive, that means that they were immunized. Okay. That's the bare bones hepatitis B, um, you know, antigen antibody review. We
Thank you
can go,
very much. I wish I would have had that years ago.
yeah. No, absolutely. Just always stop us if you need anything like that. When I work with Carrie and anyone else, if they ask that they wanted to just know, I'll tell them what we do. Anything else? Oh, Zoe has her hand up.
Hi there. Thank you so much, Dr. Garcia. I have more of like a cultural competency, cultural humility question. I noticed in the case examples that you provided, there was a client who was experiencing seizures and attributing them to spirit. And I guess I'm curious how you go about reframing like a recommendation to treatment or like ongoing care or like some kind of intervention. Maybe when a client is like attributing their symptoms to like something non-physical or to spirit or like a religious belief.
Yeah, I always say that we humans, there's dual parts to us. There's a, spiritual part and there's a physical part, right? And the spiritual part we have studied. The AMA has guidelines and studies where we have implemented spiritual assessments and guidance in actual medical school curricula because it is, part of the individual. So it is important to just know that it's not only the physical. In a lot of countries in Rwanda at least, and in Haiti, whenever we would go there and provide medical care, our patients would then go to the shamans afterwards because they understood that there's a spiritual component that we didn't take care of. And so, sometimes I offer prayer to my patients if I see that that is something that they feel important in their care. So it is something that I still address. It's not mutually exclusive is probably the biggest thing I would say. So it's not mutually exclusive. It's possible, I didn't get to ask him more of this portion in a sense of nitty gritty, but it is possible that he experienced a seizure as a spiritual component. Like he thinks that it was that, but it doesn't negate that the event had happened, that he had that episode, so that we have to keep him safe in treating him. So it doesn't actually say that, oh, you didn't have that spiritual experience, it was a seizure. But it was a seizure in which perhaps he experienced it spiritually, and that's how he is relating it to you. So it's not mutually exclusive. So I try to, with him, I said, oh, thank you for telling me. When is the last time you've had, some experience like this? So it's not negating that. Yeah.
That's really beautiful. Thank you so much.
All right. Hey, how about a shout out of some topics we could do next time?
Yeah, if anyone has any like conditions or like just health questions or something that you would have answers about or questions about in the future, if you want to drop those in the chat so we kind of have a record of that, that would also be really helpful.
And you could definitely send out that list if you have other ones over time. Pediatric conditions also, I know that we have our CHOP pediatricians, but we also, they graduate some patients to us. We do take care of peds in the office. Prenatal, that would be perhaps a good one, rhythms of prenatal follow-ups and tests. Anna said elevated lead. Carrie, you guys have that lecture with CHOP?
Yes, we had a training with Dr. Siddharth earlier this year. Ariel, do you know if we recorded that training?
Yes, it's recorded and it's actually on our landing page for RHP, which I'm putting in the chat right now because I forgot to do it earlier. So I will put that the link for that in the chat.
And we could definitely do hypertension. I think one that I would probably recommend is postnasal drip cough. That's a common one.
I think personally we're seeing a lot more diabetes as well,
Okay.
so that could also be helpful. and just like helping clients manage that and kind of in tandem with other conditions or on its own.
That sounds good. Anna mentioned chronic pain, yes, and GI concerns and medication adherence. Ooh, those are good, Anna. Yep, we'll put it on the docket. That all sounds like my jam. Chronic, primary care stuff. You got it. But yeah, thank you. All right. Any other things that and please, Carrie has my information. So if you're always welcome to shoot me an email if you just had a question. It's, you have your clinician partners, but if you just needed a little bit of just explanation on certain things or guidance on any of these things, I'm happy to be a resource.
Thank you so much, Dr. Garcia. This was great, and we look forward to part 2.
Thank you. All right.
All right, thank you. Thanks, everyone.
Bye.